Hello, and welcome to the CAP Today webinar for Tuesday, June 17th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host and moderate a Q&A session after our formal presentations. Today's webinar is entitled Amplicon-based NGS Panels in Clinical Practice, from broad oncology applications to advancing breast cancer care. This, of course, is a very important webinar, and I want to let you know it's made possible by a special educational grant from Thermo Fisher. We want to acknowledge Thermo Fisher for this and thank them for their sterling support in bringing you this and other very timely and crucial webinars. Our speakers today are Dr. Emilie Lalonde, a molecular geneticist and cytogeneticist. She's at the London Health Sciences Centre and Western University. And our second speaker, and they'll be speaking in sequence, is Dr. Cheryl Mather. Dr. Mather is the Medical Director of Molecular Pathology at the Alberta Precision Laboratories in the Department of Lab Medicine and Pathology at the University of Alberta in Edmonton, Canada. So we've got a couple of Canadian-based providers here. It's a great pleasure to welcome you. And before we begin, let me just make you a few housekeeping items that I think will help you. You'll see on your screen as the audience pods for questions. You can type at any time during today's webinar your comments, questions, comments, and other matters that we'll get to in the Q&A. Also, you can use that same pod to alert us for any technical issues that you may have, whether website or audio. We have live folks standing by throughout today to help you with those kinds of problems and questions. I should let you know we'll have the full text and audio of today's webinar posted on captodayonline.com in about a week. And you should expect some emails, both from us and from Thermo Fisher, so please be alert. And then finally, I need to remind you that CAP Today does not endorse any products or services that may be named in today's webinar. Any remarks of mine are purely personal, not to be taken as policy of CAP Today or the College of American Pathologists. And now, Dr. Emilie Lalonde will begin our presentation, and I invite her to begin. Dr. Lalonde.
Well, thank you very much. It's a pleasure to be sharing my lab's experience today with you. So we'll be discussing Amplicon-based NGS panels in practice, covering three major themes: routine diagnostics for solid tumors, an expanded NGS panel workup, and copy number variant detection in gliomas. Here are my disclosures related to today's presentation. And also, I am a recipient of a grant from Thermo Fisher. So to set the context for the first discussion, I want to tell you a bit more about our lab here at London Health Sciences Centre, or LHSC, in particular the molecular lab. We are a public lab serving a large regional catchment area covering both constitutional and oncology genetic testing indications. So you can see in this table here the rough testing volumes of the last 2 years with the solid tumor NGS and hem-onc NGS split out there. So all of this just to say that we are a pretty high volume, very busy lab doing many different things. So having a very streamlined NGS solution is really critical to the proper functioning of our lab. In terms of solid tumor testing, we do follow a province-wide standardized approach to molecular diagnostics. So this has been developed in recent years through a governmental organization, Cancer Care Ontario. I'm not affiliated with them, but CCO, along with experts from the community, identify diagnostic, prognostic, and predictive biomarkers for specific tumor types. And so these biomarkers are the genes that we are testing for in our solid tumor NGS panels. The panels that we test here at LHSC are listed in this table, so you can see the disease site, the particular indication, as well as the genes included in that panel. You will notice for any individual panel, we are testing like a handful of genes. They're not very large panels. They're very focused panels. And in terms of the workflow, when a sample arrives at LHSC, it's first going to the pathology lab where the pathologist will review the sample and order NGS testing if it meets that indication, as well as any other required ancillary testing. They'll also assess for tumor cellularity and perform macrodissection if necessary. After the sample is run through the lab and we have data to analyze, we classify variants according to the ASCO-CAP AMP guidelines, and we are only reporting tier 1 or tier 2 variants. In addition to the panels listed here, patients with advanced cancers also have an option to register for a research trial, which gives them access to an expanded gene panel. And we'll talk more about that in a few slides. So when it comes to choosing an NGS solution, of course, there's no perfect assay. There's many factors to consider. So I told you a bit about our lab, but if you were in this situation, you would also want to consider, among other criteria, potentially testing volumes, target turnaround time, resources, both human resources as well as financial and capital equipment and so forth. The breadth and the depth of sequencing required, so how many genes and how deep of a coverage required, the patient population, and the tissue types required. So for us, with all the details I gave you, we selected a mid-sized Amplicon-based NGS gene panel, which combines hotspot coverage for oncogenes and full gene coverage for tumor suppressor genes. This panel covers over 100 genes. We also couple this with an Amplicon-based RNA fusion assay, which targets about 50 fusion driver genes. For today's presentation, I'll only be discussing the DNA panel, but just be aware that we are also offering that fusion panel for many of these patients. This panel takes about 5 days for library prep and sequencing. We run samples in batches of 8, and we're able to run approximately eight batches per week, and that's with 2 or 3 technologists on that bench per week. We have a target turnaround time of 14 days. On this slide, you'll see all of the genes included on our panel. And now in blue are the ones that are actually part of one of our solid tumor panels. So of course, you can see we're only reporting on actually a minority of the genes that we are capturing and sequencing. And so we're doing in silico slices to report out on those solid tumor panels. But the genes in black do give us some flexibility in case any of these genes are later added to a provincial panel, and they're also available for that expanded NGS panel. A few years ago, our lab published our experience with the first few years of testing. So this covers the time from July 2017 to May 2020, including just over 3,000 tumors. In the table, you'll see the 4 of the more common subpanels that we test, including the genes that were on those panels at the time. So I think all of these panels have since been updated to include additional genes. And on the right, you'll see the number of patients that tested positive for tier 1 or tier 2 variant. We're going to focus on lung cancer or non-small cell lung cancer for the next couple of slides. So I'll point out that 69% of this cohort tested positive for a tier 1 or 2 variant. On the left here, we can see the particular genes that the mutations were, the tier 1 or tier 2 mutations were identified in. So over 40% of our patients had a mutation in KRAS, including 15% with the targetable G12C mutation. EGFR mutations were identified in 11% of patients. And on the right, you can see the different range of mutations identified. So of course, we see some of the common hotspot mutations, such as the leucine 858 arginine substitution, but also various exon 20 insertions and exon 19 deletions. as well as some patients with more than one EGFR mutation. And so while targeted subpanels capture high yield mutations, patients may have actionable mutations outside of standard algorithms. And studies have shown that expanded NGS panels can increase diagnostic yield, especially in advanced or metastatic tumors, rare subtypes, or patients eligible for clinical trials. However, expanded genomic profiling is largely inaccessible for most patients in Ontario at this time. So our lab explored the utility of an expanded gene panel through the POWER study, which stands for Precision Oncology at Western University. This is a single center study led by my colleagues, Dr. Beckham Sadikovic and Dr. Stephen Welch, where we are using a mid-sized NGS panel. So it's about 100 genes. It's not comprehensive genomic profiling, but it's still broader than standard of care panels. And importantly, this study was designed to prospectively assess clinical and overall health system impacts of expanded testing on patient management in a real-world oncology setting. This was done through the use of pre- and post-test surveys where clinical teams had to answer questions evaluating the clinical impact of genetic variants that were identified. So here's what we found from the first 385 tumors where the surveys were filled out. Almost 80% tested positive for a clinically relevant variant, so tier 1 or tier 2. 34% had a variant that potentially changed their management. This figure here shows that breakdown in some of the different disease sites that we test. So again, just focusing on lung, we can see that in purple, there was 45% of variants that potentially changed management and 82% that had a clinical impact overall. 8.8% had a variant of unknown significance and 8.8 had no variants at all. Digging into a bit more this question of using an expanded versus a tumor-focused subpanel, within this cohort, there were 162 patients that had prior testing with a small tumor-focused panel. Of those, 96 patients were positive for a variant by that smaller panel testing, compared to 144 patients that were positive for a variant based on the POWER panel. And overall, there were 109 variants that were identified by the POWER panel, but not by that smaller panel. And in 19% of patients, those variants actually had a potential impact on patient management. So you can see the variants that were identified by the clinical teams as potentially having an impact on patient management here, which were not identified on the standard of care panels at the time. In terms of the treatment options, so it was noted that 28% of patients became eligible for additional treatment options after the POWER results, either through clinical trials, off-label drug use, or compassionate access programs. There were also broader health system impacts noted, so 15% of patients had access to a safer treatment. This treatment sequence was changed in 17% of patients, and the Ministry of Health formulary treatment was saved in 13% of patients. So here's a case example where patient management was impacted. This is a 55-year-old male with an advanced stage colon adenocarcinoma. By immunohistochemistry, the mismatch repair status was intact. The colon NGS subpanel was negative for any reportable variant. And at that stage, the patient enrolled in the POWER study, and we reflexed to the larger panel, which identified 2 tier 1 or tier 2 variants. We have a POLB2 single nucleotide deletion resulting in a frame shift that was identified at a variant allele fraction of 53%, and an ERBB2 missense variant, a serine to 310 phenylalanine change at 40% variant allele fraction. This is a recurrent, well-known oncogenic mutation. According to the surveys, this ERBB2 or HER2 missense variant did impact this patient's management. So they were now eligible for an off-label drug use, so a HER2 inhibitor through a compassionate access program. And this also meant that they could avoid chemotherapy, which was instead saved for any potential future progressions. So with this expanded power panel, about 100 genes, we identified clinically actionable variants in about 80% of cases, and we changed management in about a third of patients. But I think that naturally raises the question of how does this, like, what else could we be missing? And how does this panel compare to comprehensive genomic profiling or CGP? I think in the field, we're increasingly facing this question of how broad of testing is broad enough. And so everything I've been discussing today really fits into this first column of small to mid-sized panel, whereas comprehensive genomic profiling would really be multiple hundreds of genes or even exome and genome sequencing, with the main, what at least I consider would be the main difference is the ability to identify these tumor agnostic genomic biomarkers, such as microsatellite instability, tumor mutational burden, and so forth. So this is really not possible with these small to mid-sized amplicon panels unless they're specifically designed with that in mind, which ours was not. On the other hand, from a lab operation perspective, that these small panels are really great. So very little DNA is required. Degraded DNA generally is still works very well. Because the genomic footprint is smaller, you can multiplex more of the data storage, and the analysis is really streamlined for the most actionable mutations. And all of this results in a lower cost per sample. On the other hand, if there was a new gene to be added to a panel of interest that wasn't included in your panel, you now have to do a spike in validation, which can be additional work. In comparison to comprehensive genomic profile, this should be relatively easy, assuming that gene is already being captured as part of the standard workup. And then finally, for CNV detection, CGP generally has pretty good genome-wide CNV detection. And with the small panels, it can either be more limited, so just to the regions being captured, but also can be more challenging. And I think it's important to point out that certainly both approaches have value, and which solution should be selected based on laboratory considerations, of which we've talked through a lot, but also the clinical scenario, testing access, and therapeutic implications. Okay, so for this last portion of the talk, we'll move on to talking about gliomas, and in particular, looking at copy number variants or CNVs using the same amplicon panel. So both single gene CNVs as well as larger segmental aneuploidies, such as whole arm or whole chromosome changes, are really imperative for an integrated glioma diagnosis according to the World Health Organization criteria. The particular CNVs of interest are listed in this table. So we have 1p 19q whole arm codeletions. This is required for a diagnosis of oligodendroglioma. Then there's trisomy 7 with monosomy 10, as well as EGFR amplification. Both of these are molecular features of grade 4 glioblastomas, so supporting that diagnosis. And then CDKN2A homozygous deletion will change the grade to grade 4 for astrocytomas. At our institution, most glioma tumors were getting both NGS to look for sequence variants, as well as FISH testing for these specific CNV biomarkers. Unfortunately, a few years ago, we were having delayed results from our FISH CNV reporting. And so the opportunity came up to see if we could call these CNV biomarkers from our existing NGS panel. CNV detection by NGS is, of course, already well established, but it can be more challenging with smaller amplicon panels. And with this solution, we do use a read depth approach. So just very briefly, where the coverage of reads to a specific locus is used to infer either a deletion or a duplication of your region of interest. We designed a custom analysis to use this panel to detect segmental CNVs. So in this slide, we'll walk through the example of a 1p deletion. So using standard software, we obtained normalized gene level copy number variance for all genes in our biomarkers of interest. And so for all of our biomarkers of interest, we'll take the average copy number of all the genes in that region, so all the genes in 1P. But we also look at the average copy number of a control region. And for 1P, that control region is chromosome 1Q. So for all of our biomarkers, we're looking at the absolute copy number of that biomarker and also the ratio to a control region. This is pretty simple, and it's also quite similar to how FISH analysis is done for these biomarkers. Through our validation studies, we identified two sets of thresholds. One is a stringent threshold where a CNV could be reported directly as positive from NGS. So this particular example would fit that criteria. It's clean and it's well below our established cutoffs. But we also have a more lenient threshold, which will identify more like gray zone or inconclusive samples where there's still some uncertainty whether it's really positive or negative. And for those, we do still reflex to FISH to get an accurate answer. And then if neither of these thresholds are met, we can report negative from NGS and skip the FISH in that case too. And just quickly here, highlighting why we think it's important to look at that ratio to a control region. Again, looking at chromosome 1P. In these figures here, you'll have the FISH results on the x-axis, where each dot is going, or shape is going to represent a tumor sample. So in this first column, these samples tested positive for 1P deletion by FISH, as did the patients in the second column, but it was a relative deletion. So there was a deletion with polysomy 1. And then in the last column, patients tested negative for 1P deletion. On the left, on the y-axis, we have the average copy number of the 1P region based on our NGS panel. And you can see most of the patients with a deletion are separated fairly well from the normal or negative patients, except for this set, these three tumors here who were found to have a relative deletion by FISH. And so when we switch over to this figure on the right, and now the y-axis is showing the ratio of 1P to 1Q by NGS, we can see that those three samples are now being rescued essentially by this ratio. So they're falling in the same range as our other deleted samples. And overall, through our validation studies, we had very good results. With near 100% concordance, there was only one potential false negative by NGS for a CDKN2A homozygous deletion. This was a very low level deletion, like in a very low number of cells by FISH, and it's still being worked up as it may also represent a false positive by FISH, but I included it here nonetheless. The other important criteria, though, aside from concordance, is the reflex rate, as this tells you how tight essentially we can be with our cutoffs. So you'll notice, for instance, trisomy 7 and monosomy 10, we have almost a quarter of patients still need to reflex for that biomarker. But I will point out that most of them are turning out positive when we do reflex to FISH. So as we accumulate more data, we think that we'll be able to kind of tighten those thresholds. And importantly, from an operational perspective, since adopting this strategy, we've seen an 87% reduction in FISH assays that need to be performed. So this is a really big win for our cytogenetics lab, as now those technologists can be working on other critical assays that lab is working on. And for both the pathologists and for the patient, this is resulting in faster turnaround time for the CNV biomarkers, as well as a faster integrated diagnosis, ultimately. Okay, so the key takeaways from this lecture are that small to mid-size amplicon-based NGS panels are a pragmatic solution for routine solid tumor testing. They're high yield, fast, and cost-effective. They can also be used to perform expanded NGS testing in patients with advanced cancers. And we have shown that we identify additional clinically actionable variants. And this has an impact on treatment decisions. And finally, with this panel, we were reliably able to detect CNVs, though having robust validation data is really important for benchmarking these segmental aneuploidies using a targeted panel like this. So at this point, I'd like to thank you for your attention and also acknowledge all of my colleagues at the Molecular Diagnostics Lab at LHSC. They're the ones who kind of keep this workflow running day in and day out, as well as my colleagues involved in the POWER study and the glioma CNV studies. Thank you.
Dr. Lalonde, thank you so much. That's a wonderful lecture that you've given us, as clear a schema for understanding panels, large and small, and the proper workflow. That's indeed highly, highly desirable. Wonderful lecture. Allow me now to remind the audience at any time on your pod, you can type in your comments, you can ask your questions, etc., and we'll get to those after our next and final formal presentation today. And that will be by Dr. Cheryl Mather, as I said before, Medical Director, Molecular Path in Alberta at the University of Alberta in Edmonton. And I will ask Dr. Mather to begin now. Dr. Mather.
Thanks, Bob. Excuse me. Good morning, everybody, or good afternoon, depending on where you are in the country. So today I'm going to focus on using Amplicon-based panels to advance breast cancer care and really discuss the theoretical benefits and limitations of using some different sized panels to evaluate patients who are being worked up for eligibility for AKT, mTOR pathway inhibitors, such as the PIK3CA inhibitors and the AKT inhibitors. Let's see if I can get this. There you go. There are my disclosures, very similar to Dr. Lalonde, and a brief agenda. So to highlight the pathway that we're looking at, most breast cancers that are hormone receptor positive and HER2 negative will be treated with estrogen receptor inhibitors. And over time, these patients will develop estrogen resistance through activation of the mTOR pathway and the AKT pathway. So although ER inhibitors work for a while, eventually patients acquire mutations in the PIK3CA or PIK3 kinase pathway, PTEN, AKT, and other pathways that will potentially bypass this pathway and make them endocrine resistant. There are a number of drugs in either development or offered as FDA-approved therapies in these patients that target this pathway. And the different pathways target the PIK3 kinase, the mTOR pathway, there's dual inhibitors or the AKT pathway inhibitors. In Alberta, we were fortunate enough to get industry funding to test for capivasertib eligibility pre-provincial approval of this drug. And that allowed us to offer testing for the mutations in PIK3CA, PTEN, and AKT1 that would make patients eligible for this therapy. But when we got that funding, the question was, how are we going to do it? So it turns out that most of the patients who are capivasertib eligible will have mutations in PIK3CA. And hotspot testing of PIK3CA was very tempting for us because it was cheap, easy, and fast to perform. But we wanted to know whether or not it would be comprehensive enough to pick up the patient population that would actually be eligible for the drug. So we first looked at the mutational spectrum of the mutations that we were going to potentially expect to see in these patients. So oncogenes like PIK3CA and AKT1 are quite amenable to hotspot testing because they typically have hotspot mutations, single point mutations that activate the protein and are recurrent in a large number of patients. In PIK3CA, for example, the hotspots generally occur at positions 542, 545, and 1047. These other mutations are potentially activating as well, but are less common in our patient population. In AKT1, it's very attractive to do hotspot testing because the majority of patients will have a single point mutation in E17K. PTEN, on the other hand, as a tumor suppressor, is much harder to target with a hotspot test. Although there is a hotspot mutation at position 130, you can see that inactivating mutations and point mutations occur across the entirety of the gene, causing inactivation of the PTEN protein downstream. So doing a hotspot to find all of these background patients would be very, very difficult. So we first evaluated the idea of maybe just doing a hotspot test for PIK3CA alone. Would it pick up enough patients that we were essentially getting good but not perfect results and using the most health economically feasible way of identifying the patients who would be eligible for this drug? The panel that we evaluated tests for 19 point mutations across 5 amino acids in PIK3CA. Only takes about 1 day to set up and interpret, and was very, very inexpensive as far as molecular tests go at $200 a sample, including our technologist time and pathologist sign-out time. We also evaluated a more comprehensive or mid-sized panel to see if that was a better option for catchment for these patients. Comprehensive testing or more comprehensive testing is typically an NGS-based solution. And as Dr. Lalonde said, this can typically be either a DNA only or a DNA and an RNA-based solution to look for point mutations, insertions, deletions, copy number analysis, and potential fusions. These different NGS-based panels can be variable and go from 1 exon to the whole genome, depending on what you're looking for and what you're trying to evaluate in these patients. When we talk about comprehensive testing, we're talking about things that are generally 300, 500, or bigger gene panels. But some of these panels, like the one we use that are considered more mid-sized testing, can do a lot of the same things that a comprehensive test can do. So Alberta has a cancer biomarker DNA panel that is a mid-range comprehensive sequencing solution. And the reason I call it mid-range and comprehensive is because it only tests for about 130 genes. But it covers the hotspot exons of oncogenes and full exon coverage of tumor suppressors, and detects almost all the mutations that we would care about in the 3 genes that were eligible for capivasertib therapy. We're also, because of the way the panel was designed, able to detect deep deletions in PTEN from a single exon to full gene deletion. This takes about 7 days to set up and run, and we have the data interpreted by standardized variant interpretation in cancer consortium, or VIC, criteria by our certified molecular pathologists. And unlike that hotspot panel, it's a little more expensive. It costs us about $700 a panel to run. We do, however, run multiple bioinformatic platforms on this particular sequencing data to evaluate copy number, where we can evaluate both amplifications and deep deletions of individual genes and portions of whole chromosomes. And we tie that in with a SNP or based approach to look for loss of heterozygosity to confirm those copy number alterations called by the software. This allows us to get down to 1p and 19q deletions at levels around 20% tumor fraction and prevents us from having to send those to the fish the way that Dr. Lalonde's panel does. But it takes specialized design of the panel to accomplish this. Our panel also includes a MSI caller that is better than nothing, but probably not ideal. And allows us to look at SNPs and indels across those 130 genes. Unlike Dr. Lalonde, Alberta does not have the limitations on which genes we're allowed to report in different tumor settings, so we generally evaluate all 130 genes in every patient. This is more time-consuming and potentially less clinically actionable in any given patient, but does allow us to know what we're not seeing if we were to bioinformatically mask those patients. What we're obviously looking for in these patients with breast cancer are these PIK3CA hotspot mutations or AKT1 mutations, PTEN deletions, or truncating mutations, or that hotspot at 130. The drug was actually approved based on comprehensive hybrid capture-based sequencing, and that was the Capitello 291 trial. This was 2 very specific panels that were between 300 and about 520 genes. And we're able to detect everything that we detect in those 3 genes, SNVs and indels, copy number variants, and select rearrangements, although it didn't include PTEN rearrangements. And we are also limited in that we cannot detect PTEN rearrangements. Each of these tests, if we were to send them out, costs over $2,000 Canadian, which is substantially more than our $700 price point. In the Capitello 291 trial, about 85% passed QC, which does not include, as far as I could tell from reading the trial, those patients that didn't even make it onto the sequencer because of insufficient DNA quantity. And that's going to become important in the next slide. About 70% of their patients had sole mutations in PIK3CA that made them eligible for capivasertib. And then about 30% that were eligible for drug were eligible on the basis of either combination of mutations in PIK3CA, PTEN, or AKT1, or sole mutations in AKT1 and PTEN. In Alberta, with our patient population, about 89% passed QC, and just over half of our patients had alterations in that PIK3CA AKT pathway. This, however, is a little bit misleading compared to that Capitello 291 cohort. When I say that 89% passed QC, I mean that we sent almost everybody to sequencing. We will test DNA samples down as low as 0.1 nanograms per microliter by qubit quantitation, and it's only about 11% of those that fail. If you take the Foundation Medicine website as the gold standard for what they require, the recommendation is for at least 55 nanograms of DNA from any given patient. When I looked at our patient cohort and actually did the back calculations, only about 75% of our patients would have that much DNA available for testing. So if we were to send it for a comprehensive sequencing analysis, it would probably be a large proportion of patients that would either become NSQ or failed by their analysis, just because we have very small biopsies and limited material available. Our patient population was similar to the comprehensive analysis in the Capitello trial. About 75% of our eligible patients had PIK3CA alone, and about 8% had mixed PIK3CA and other mutations. So we're seeing very similar proportions of patients with these mutations, but certainly it's not just PIK3CA. So we did the thought experiment. Our CBC detection rate is about 50.4% that were altered and eligible for drug. And our hotspot theoretical detection rate, if we went with that 19 hotspot panel, was only 34.3% of the patients. So a large proportion of the patients that would be eligible for drug by the mid-range panel would be ineligible on the basis of that hotspot test. And although it's tempting to use that very cheap, very quick turnaround time, that's a large proportion of patients that would not be eligible for potentially life-improving therapy. Additionally, what else are we missing? So a more comprehensive assay allows the evaluation of more genes than just the ones that are offered for drug. We are able to find ESR1 mutations for which there are clinical trials in breast cancer, and potentially mutations in hereditary breast cancer genes that need additional follow-up by our medical geneticists. We have ATM, BARD1, BRCA1 and 2, CHEK2, NF1, PALB2, and some of these others on our panel that would prompt referral to medical genetics if seen at high enough allele fractions in the tumors. Additionally, there are other hereditary tumor syndromes that we can pick up as ancillary findings in these patients, assuming that they want to know. We actually allow them an opt-out according to our agreement with the drug company that paid for our testing, that says if they don't want to know about potentially hereditary findings, we won't report them. But most, in fact, 90% of our patients opt in for that. And so we can find mutations that would lead patients to a diagnosis of Lynch syndrome, Dicer mutational syndrome, SDH mutations, BAP1, BRIP1, and some others that might potentially have familial implications. And we do regularly. In the first 414 patients that we sequenced, we found 31 patients with ESR1 mutations in their tumor specimens, which might be eligible for other therapies. We found 68 patients with mutations outside of PIK3CA, PTEN, and AKT1 that could be hereditary and needed workup by medical genetics. And we found 10 patients with possible other hereditary syndromes that were unexpected in the breast cancer setting. What else could we find? So one of the benefits of using a very comprehensive panel is that you have opportunity for discovery. And the more genes that are present on that comprehensive panel, the more, quote, free discovery the lab gets. But there's a moral dilemma with this approach, especially when you talk about the benefits or the limitations of doing a comprehensive panel for turnaround time, required quantities of DNA, and the clinical applicability of those mutations in the setting of active cancer in those patients. So just to make this a visual idea, from hotspot to comprehensive testing, we have costs ranging from $200 to greater than $3,000 a sample. You go from one locus, potentially at the minimum, all the way up to whole genome or whole transcriptome. And your turnaround time could be as short as 1 day or as long as 4 to 6 weeks in the tumor setting. So these things all come at a balance. And you could imagine that the clinical utility is maximized at a certain number of genes. So as we showed that PIK3CA hotspot example, that's not going to have the clinical utility that would be maximized for the patients that were eligible. But the comprehensive greater than 300 gene panel tests far more than the 3 genes that we are potentially looking at for drug actionability. So you might argue that the clinical utility of the panel, given the turnaround time and cost considerations, is actually maximized in these mid-sized panels, depending on how they are designed and what you're trying to find in individual patients. Amplicon-based testing, because it requires less DNA than some of these comprehensive hybrid capture-based solutions, does tend to have a lower failure rate compared to hybrid capture-based testing, and a higher detection of actionable mutations compared to hotspot testing. There's a lower cost compared to sending out those testing with that comprehensive panels. And at least in our hands, we feel like we have equivalent detection of the targetable mutations compared to those comprehensive panels. There are some limitations compared to doing hotspot testing. There's slower turnaround time, and it's a higher cost compared to those smaller panels. And any Amplicon-based panel does have the potential for PCR-induced errors and artifacts, particularly at those very, very low DNA inputs. Additionally, you only get what you look for. If you're looking at 130 genes, you won't find mutations in the other 270 or 370 associated with the 500 gene panel. And with that, I'd like to thank you for your attention, and Dr. Lalonde and I will answer any questions that you have.
Thank you so much, Dr. Mather. Again, for those of you in the audience, you've heard 2 spectacular presentations on approaches to workflow, size of panels, and optimizing care for patients with some eye to the optimal expense and cost and yield of various kind of panels and approaches. It's an absolutely fascinating webinar. And now I will ask Dr. Lalonde to unmute herself, and we'll begin some Q&A. We have a lot of questions, and we'll get through as many as we can. I'm going to start with Dr. Lalonde. In her presentation, what was the volume per run and the platform that you used to run the smaller panels? Can you remind us?
So the same panel was used for everything I discussed, and it's like a 130 gene amplicon-based panel, and we run 8 samples per run.
Very good, thank you. And then asking you about the glioblastomas, are these being sequenced with brain biopsy tissue or liquid biopsy material?
Yes, it's the primary brain tumor.
Very good. Thank you very much. There's really a question for both of you that I want to make sure we clarify. And I'll ask you first, Dr. Mather, and then Dr. Lalonde. Could you clarify why the number of reported genes is lower than the number of sequenced genes? This is an important question and deserves an important answer. Dr. Mather, I'll let you go first.
Great, thanks, Bob. So I think every lab has this discussion at the development of a mid-sized or larger panel. Every tumor indication has certain genes or certain abnormalities that have actionability in that patient. And not every one of the 130 genes on our panel is going to be clinically actionable in every patient. So there is a somewhat philosophical discussion as to whether or not you evaluate every gene in every patient and report everything that you see in every patient, or whether you bioinformatically or otherwise mask that information so that you're only reporting the things that are available via guidelines and or provincially funded indications to maximize the clinical utility at the present time for those patients. That doesn't mean the data is not present and you couldn't go back and evaluate it if indications changed. But certainly when we talk about trying to maximize the actionability of those results for our clinical colleagues who are otherwise overwhelmed with very high volumes of patients and information, sometimes less is more. And so in Ontario, they actually only fund certain genes to be reported for different tumor types. In Alberta, we do report all genes in every patient, with some notable exceptions. Our MMR deficient endometrial tumors, we will report the meaningful mutations in the MMR genes that cause that MSI high phenotype, the meaningful negative of POLE hotspot mutations in the exonuclease domain, and any other mutations are actually potentially hidden, but with a comment that the fully annotated list can be provided upon request. In other patients, we're focusing our attention on certain copy number abnormalities that have high clinical actionability and ignoring them in patients for whom the clinical actionability of those copy number abnormalities is unknown at this time. But we always make that very clear in our reports and offer the full information to our oncology colleagues if they request it.
Dr. Mather, thank you very much. Dr. Lalonde, would you care to comment on that same question?
I think that was really well articulated. Absolutely, there is a trade-off. And maybe just the other additional note I would put in is that these clinical assays, they have to be locked down. So at the time of our design, we're going to look at all of the genes we're capturing. If any of them have potential clinical actionability, those are the ones that we're, even for our expanded panel and in my talk, that's what we would include. But if we're only ever going to be seeing variants of uncertain significance, we don't want that on our reports at this time. And then, for our solid tumor focused panels, we are following an Ontario provincial mandate for which biomarkers we're reporting on. And those are really based to be like the highest clinical yield. They are updated fairly regularly. So they are very meaningful biomarkers that we're reporting on. Thank you.
Thank you very much, both of you. We're raising now really the fundamental question, and we have an audience member who's asking it. You mentioned the question of how broad is broad enough regarding the panel. And could you share your insights about it, the inverse of that question? How broad is too broad? That is to say, examples of providers chasing down non-clinically relevant variants, undue price and stress that may be brought about, insurance eligibility, and a whole host of other topics that I'm sure we could put in that same bucket. I'm just interested in your general reaction to that question. I'll let you start, Dr. Lalonde.
Yeah, thank you. I think that's a really insightful question. And it does come down to philosophy in some respects. I will also point out that the regulatory landscape is very different in Canada than in the US. So to take that into account, and I may be a little biased, but I do really like the approach we have here. Whereas for these, at Diagnosis, we are really focused on getting those high yield, immediately actionable variants and biomarkers. But certainly for those patients with the advanced and metastatic tumors, having access to broader testing can be beneficial. I think it does come down to, whether you're approaching it from the clinical side or the lab side, there's so many different criteria you need to take into account. What other ancillary testing is being performed. So yeah, I don't think there's a right answer here. You have to take very many different factors into account, but I'm interested in hearing what Dr. Mather has to say.
Yes, Dr. Mather, same question.
So I tend to agree that this is a very tricky balance to find, and we're all looking for that Goldilocks solution. The things that we consider when designing our panels are the indications. Certainly, we want to maximize our throughput on our sequencer with multiple indications running on the same panel so that we can shorten the turnaround time because our batch sizes get filled much faster. The second consideration is cost of the panel. Certainly we have provincial funding as opposed to insurance paid testing. And we have a very limited budget for a very large number of patients. So we're always very conscious of the cost of those panels. The third is turnaround time and when the test is being ordered. So for patients who are being sequenced at the time of metastatic diagnosis for prostate cancer, for example, they may have months to years before this information is clinically necessary for the use of olaparib therapy in metastatic castration-resistant prostate cancer, because most of the time when they're diagnosed with metastatic disease, they're castration sensitive. On the other hand, our breast cancer patients were tested at the time of essentially just in time, the time where they would be eligible for capivasertib therapy as their next line of treatment. So they'd been on CDK4/6 inhibitors for many months, or they were failing CDK4/6 and inhibitor therapy and needed immediate change in management. Those patients can't wait weeks to months to get their results. They can wait potentially the 2 to 3 weeks that it takes us to get them an answer. And so a panel that is very, very large, particularly if it's comprehensively analyzed, takes a long time to analyze because there are many, many variants that need to be worked up, and many of those are going to be variants of uncertain significance that have no clinical actionability at the current moment. So when you talk about how broad is too broad, I would say any panel that doesn't get you the information you need at the time the patient you need it is too broad. So I think that's a moving target depending on when we sequence these patients and what we're evaluating in terms of the bioinformatic masking or other limitation of that data being sent to the molecular pathologists or genome scientists who are doing the variant interpretation work.
Thank you. Thank you so much. I wanted to wait until this moment. You've heard a lot about provincial funding, and we're talking about two different provinces of Canada, of course. But I do want to mention that Dr. Mather trained at the University of Washington in AP and CP. She had a molecular pathology fellowship at UCSF. And Dr. Lalonde trained at the Children's Hospital of Philadelphia at the University of Pennsylvania. So they're intimately aware of the differences in medical practice between Canada and the United States, just for what it's worth. We have another question here that I think is a very good one, and this for you, Dr. Mather. At what point in the patient's journey, diagnosis 1L, 2L plus, are you testing metastatic breast cancer patients? If at diagnosis you do a test for ESR1, and if you do that, since it's an acquired resistance mutation, are you testing at every progression of the patient?
Very good question, and that's not an answer that I can give at the current moment. So we are currently testing patients at the end of first-line therapy. So when they would be eligible for the drugs that we have provincially available, that would be second-line therapy for these patients. And so we are trying to test the patients for whom the data would be immediately actionable. The ESR1 at the current moment, because we have no provincially funded indication, if we find it, it's a nice to find, but it's not something that we are generally looking for. We are considering and discussing how we're going to evaluate those when the drugs become available to us. And that is a very challenging discussion to have. Depending on which trial that you're looking at for the ESR1 drugs, there was a one and done at the time of progression for one of the trials, and there's an every 3 months for 5 years or until positive for the other trial. And these were both done on cell-free DNA as opposed to tumor tissue. So if we're considering cell-free DNA as a separate indication, that comes with a whole host of bigger challenges, the biggest of which being the depth of sequencing coverage needed and the cost associated with that if you're doing an NGS-based solution. So we have considered different possibilities for ESR1. We've certainly planned to test at progression and potentially at every progression for those patients. And the current thought is that we would be doing cell-free DNA to capture the whole tumor microenvironment whenever possible. The question that we have in our minds is whether we'll be doing that on an NGS-based solution that would be more comprehensive, or on an ESR1 hotspot qPCR or ddPCR-based solution. Of course, the latter two solutions are cheaper and faster, but are more limited in what they're able to detect. But depending on the number of patients that we would have to test, we may have to go that direction because we have limited throughput on our sequencers for that number of patients. If we use the Serena trial Q3 months until positive as our model, we estimated that on our metastatic breast cancer cohort in Alberta, we would top out at a steady state of around 3,000 tests a year required for those patients just for ESR1. And certainly that's not something that we want to accomplish by NGS because we can only run 8 at a time on cell-free DNA. So we simply wouldn't have the resources available to do that. So that's something that we're considering right now. It's very likely that we will be testing either once or basically oligo testing once or twice at progression for these patients, and in which case a ctDNA NGS solution is probably the direction we're going to go.
Thank you very much, Dr. Mather. Excellent, excellent question, excellent response, if I may say so. We're getting towards the end, so I'm going to ask one final question of Dr. Lalonde, which is, are there Amplicon-based NGS panels specific for central nervous system tumors? I suppose you mean other central nervous system tumors. Could you give us a reply to that?
Yeah, so certainly there have been some published in the literature of some groups designing specific CNS panels. I have to admit, I'm not aware if there's any commercially available panels with a CNS focus. In our lab, we use kind of a pan-tumor panel, and we kind of retrofit it for our CNS needs. But if I have seen quite a few in the literature that will call CNVs for the CNS tumors as well as the sequence variants. And there are really nice papers on this if you do a quick search.
Very good. And Dr. Mather, would you just care to comment about other Amplicon-based NGS panels in your area of practice?
Certainly, there are many NGS-based Amplicon-based panels that are available. Some are commercial and some are LDT. And depending on the panel design and your specific needs, you may want to go one direction or the other. If your lab has limited exposure to laboratory developed tests, some of these commercial panels are much easier to implement and would be easier to validate because they're the amplicons are well curated and we know the uniformity is very good across that panel. If you're going to develop your own panel, some of the considerations with an amplicon-based design are getting help to design the appropriate amplicons and making sure that when you do test that panel that you identify those amplicons that underperform so that you can either mask them or ignore them when you're evaluating your panel. So finding the right number of amplicons across the number of pools that you need to generate to create your libraries, making sure that they all perform with relatively uniform amplification and that you're collecting and identifying the mutations that you want to see across different GC contents of those amplicons is very important.
Thank you very much. I'll give you the last word, Dr. Mather, and begin to wind up here. You've heard two magnificent lectures and a wonderful question and answer session, all of which will be put on captodayonline.com in approximately 1 week. I'm sure you'll be anxious to review this, also to share this webinar with colleagues who did not have a chance to be with us live today. So it's a great pleasure. So of course, I want to thank Dr. Emilie Lalonde and Dr. Cheryl Mather. They've been extraordinarily good speakers today and have transmitted lots of good information on workload, on the science of this kind of testing and the proper size of panels. It's a lot to think about, and you've got to keep up with the literature, as you both mentioned in your presentation. So I want to thank you very much. I also want to thank Thermo Fisher for their special educational grant that has brought us today's program. It's really highly valued by us, and I know it is by you. We can't do these things without this kind of help. So thanks to Thermo Fisher. And finally, and lastly, I want to thank all of you in the audience. We have a huge audience today. I know your time is very important and you're very, very busy. Most people in labs in Canada and in the United States were certainly shorthanded and have plenty of work to do. So when you take time out to join us on a CAP Today webinar, we are really very, very grateful to you, and I want you to know that. So finally, just to briefly wrap up once again, thanks to Dr. Mather, thanks to Dr. Lalonde, thanks to Thermo Fisher for their sponsorship, and thanks to all of you in the audience. With that, I will bring today's webinar to a close.